Thank you, Mindray and Shama, and moreover, Mr. Manoj, who is coming to our lab. I am working as a professor in the Department of Pathology as a unit head of clinical chemistry section. And choosing this topic, actually, since long, I am working in the field of clinical biochemistry, as well as my area of interest is lipid biochemistry. Moreover, most of the laboratory we are doing lipid profile as a traditional test. So should we go ahead still with traditional lipid profile, because I am working in KGMU and cardiologist many times asked me a question, Dr. Wahid, our lipid profile report is quite normal, quite okay, triglyceride is okay, total cholesterol is okay, HDL is in the good range, but even if the subject is suffering with a recent MI or cardiovascular event. So what is the thing behind whether the traditional marker we should think on that, or we should look for some other newer markers that is upcoming. So considering these things, I have chosen this topic, that whether the good cholesterol is still good or it is something else behind the scene, behind the curtain. We are okay that our good cholesterol or HDL is beyond 50, beyond 65. I am thinking that our HDL level is okay. I am prone to with cardiovascular event. I am protected. I may not have the recent cardiovascular event in future. Looking that, we have prepared this slide that the burden of cardiovascular disease looks like that. We are overburdened, and the cardiovascular disease is the leading cause of death globally, and approximately 17.7 million are suffering every day globally with the cardiovascular event. And in that, high density lipoprotein serve as a protective response, whereas low density lipoprotein cholesterol as a risk factors for coronary artery disease. This is the leading cause of death globally. If we see the data from 2000 to 2012, we could see here that the increasing rate of incidence of stroke, ischemic heart disease, and respiratory disease along with diabetes, they are increasing day by day. And the risk factors that attributed about more than 50% of total risk is due to the lipid factors, or lipids and lipoproteins. And we know that some risk factors, they are modifiable risk factors, and some are non-modifiable risk factors. We can easily modify by active lifestyle intervention, dietary changes, and further things like dyslipidemia, raised LDL cholesterol, triacylglycerol disturbances, low high density lipoprotein cholesterol, smoking, hypertension, diabetes, obesity, PCOD, etc. Whereas non-modifiable like genetic risk factor, age, sex, family history, and other things. We can define dyslipidemia that there is a change in the cholesterol level, in the triacylglycerol level, as well as there is a change in ApoB content of the lipoprotein, LDL, and LPA, that is recent marker, that is upcoming marker, and concentration of the HDL like ApoA1, that is HDL-associated proteins, that is ApoA1, and these disorders may be primary or to secondary with the disease. This is the evolution of atherosclerotic plaque. I am not going in detail due to constraints of time. There is a direct relationship between HDL cholesterol and incidence of CHD, and the level of HDL more than 75 associated with longevity or receipt of longer healthy life. Thus, the goal is that the primary reduction in HDL cholesterol are in common patient with premature CHD. Low HDL levels are seen in patient with first myocardial infarction in more about 19%, whereas some study shows that the 52% patient with CHD with normal LDL and low HDL cholesterol. Various studies shows that the like CARE studies and some Birmingham heart study shows that myocardial infarction increases by 25% for every 5 milligram per deciliter decrement in HDL below median values. Data showed here that the risk of myocardial infarction increases by 25% every 5 milligram percent decreased in the HDL level. And NCEP ATP third panel shows that HDL level below 40 constitute an independent risk factor for coronary artery disease. Just to show here how the structure of HDL particle looks like, that is ApoA1, ApoA2, cholesterol ester and triacylglycerol rich particle. This is the denser particle, smaller in size, and the production of HDL cholesterol by de novo and by the reverse cholesterol transport. So HDL as antithrogenic mechanism by two mechanisms, that is the reverse cholesterol transport from peripheral tissues to again the liver, and cholesterol ester transfer protein that transfer cholesterol from VLDL to IDL, LDL and cholesterol ester transfer protein. This is the mechanism how the reverse cholesterol transport system happens, and cholesterol ester transfer protein play a major role in the production of reverse cholesterol transport and VLDL. Now here the scene is that whether at the level of 50 or 60 or 75 milligram per deciliter is still protected or not. Where our functional HDL that protect us from the incidence of MI or cardiovascular event, whether it is still considered as a good or something else is going on. Then the functionality aspect of the HDL should be assessed. Is that the HDL cholesterol levels is only a part of the HDL story, because we have to look into the particle, we have to look into the content. The particle matters whether the functionality aspect of reverse cholesterol transport system is going on or not, properly it is done or not. Then it does not give an indication if the HDL particle is functioning properly or not. Here, an study has been taken, that is the HDL assumption called into question by multiple studies from 2012 to 2017, that there is a U-shaped curve of HDL concentration. Means at below 40, there is increased hazard ratio or mortality, whereas when the HDL concentration is beyond 70 or 80 milligram per deciliter, there is also increased hazard ratio. It means that if your HDL is below normal or above normal, it means that you are at equal risk. You are at similar risk. Where there are various trials, they are raising for HDL cholesterol, did not reduces the risk of cardiovascular event, like having very low or very high HDL levels indicate to increase the mortality, and raising HDL cholesterol levels with different drugs like niacin and other factors, they fail to reduce the risk of cardiovascular event. Moreover, the story is not only for HDL, it is as applicable for LDL as well as triacylglycerol as well. That here the study was conducted by Sachdeva et al. In 2009 and many other studies, that most people who develop CHD they may have normal LDL cholesterol. And we can see here the incidence of CHD with the persons, they are suffering with CHD, that is at the level of 130, below 130, and at the level of 70 milligram per deciliter, the incidence of myocardial infarction is still high. And 23% had LDL cholesterol beyond 70 milligram per deciliter. So what does it mean? Whether normal LDL or low LDL is okay, or we have to look into the matter, whether behind the LDL there is some other fraction like a small dense LDL that is more atherogenic to develop atheromatous plaque. Same is here, like that triglyceride level patient done on the analysis of 1,36,955 hospitalized patients, and showed here that the 60% patients with the myocardial infarction have shown the triglyceride less than 140 milligram per deciliter. And the scene is also looks like that. 52% had HDL cholesterol more than 40 milligram per deciliter. So what is the mechanism, what is the theory behind that? At the level of normal LDL, above normal HDL level, below normal triacylglycerol, the incidence of CHD and cardiovascular disease is still very common. So behind that, one theory has been given that the small dense LDL particle, LDL has some subfraction, isoforms of the particle, that is a small dense LDL and large band LDL. The small dense LDL behind the total LDL, that is the major player in the risk assessment and risk development and leading to the cardiovascular event. And the reason is behind that the lower affinity to hepatic LDL receptor, a stronger affinity with the vessel wall, and more rapid oxidation, accelerated oxidation. Your LDL is normal, but that LDL is become oxidized, that is more atherogenic, more serious event is there. We can see here, and we can very well compare that at both the level, one patient is healthy patient, another is scared patient. Here the level is 140 in both the cases, and you can see here in healthy men the small dense LDL cholesterol level is only 20 milligram per deciliter, whereas in scared patient the small dense LDL level is about 90 milligram per deciliter, means at the equal level of LDL cholesterol, one person is with cardiovascular event and another person is healthy. It means there is a small dense LDL that is the major player in the development of cardiovascular event. Here we can see that normal size, normal number, no risk, large number of LDL with normal size, intermediate risk, and a small dense LDL but a small number, low risk, large number of small dense LDL at a high risk. So we should think whether our total LDL is responsible or in behind the LDL, how the concentration of the small dense LDL they are behaving, what is the level, what is the concentration of a small dense LDL in between the total LDL. Now the theory again comes to the HDL, no more as a good cholesterol. Why? Because there is a recent theories that shows that Birmingham studies of incidence of coronary heart disease shows that 44% of the event occurred in men with HDL cholesterol levels of at 40 to 40 milligram per deciliter, whereas 43% event at 50 milligram per deciliter. It means that a significant number of CHD event in patient with normal LDL and normal HDL cholesterol. So therefore, we have to search, we have to look for the novel markers, for the recent markers that is upcoming. So quantity does not reflect the quality. Irrespective of quantity, what is the quantity of our LDL or what is the quantity of our HDL? It is the functionality, whether the particle that is as well functional or not, whether the reverse cholesterol transport theory is still working or not. So HDL function can be assessed through the number of HDL particle, various size of HDL particle, integrity of HDL particle, as well as some inflammatory markers, that is myeloperoxidases and oxidized low density lipoprotein cholesterol that has a major role in assessing the HDL functionality. There is pro-inflammatory theory, that is that ApoA1 convert into HDL into pro-inflammatory, that is become non-functional. Macrophage retain increased cholesterol, and by reverse cholesterol transport is reduced, and myeloperoxidases modifies the tyrosine amino acid residues, and that become dysfunctional HDL, has increased hydroperoxides and make it anti-inflammatory to pro-inflammatory. I have to skip few of the slides due to paucity of time. The heterogeneity of HDL in component renders these molecules very susceptible to alteration in various aspects like cholesterol transfer protein, SR beta 1 scavenger receptor beta 1 protein, ABCA1, PON1, pyroxenase, LCAT, ApoA1 and ApoA2, and free cholesterol, cholesterol ester, hydroperoxide, phosphatidylcholine, membrane phospholipids, and other factors that are associated with modification of or attenuation of HDL particle. So here we can see that the physiological HDL become antioxidative, anti-inflammatory, anti-apoptotic, and antithrombotic, and after become it is dysfunctional or it become attenuated, become dysfunctional, that become pro-oxidative, pro-inflammatory, pro-apoptotic, and pro-thrombotic activity. There are various conditions where dysfunctional HDL could develop, like in cardiovascular diseases, in metabolic diseases, in chronic inflammatory conditions, in kidney disorders, and in various other conditions where HDL functionality become disturbed. And in coronary artery disease, why the reduced HDL or dysfunctional HDL is associated with reduced PON and HDL activity, reduced inhibition of monocytes, reduced inhibition of oxidation of LDL, and various other factors that are responsible for HDL functionality, and here we could see here. Now, considering these factors, we have chosen two markers like PON and SR beta 1 as a pilot study in our King George's Medical University, collaborated with cardiology department, and we have recruited few of the angiographically proven cases of coronary artery disease and study will show how the result we have find. So PON1, it is an HDL bound aryl esterase enzyme, that is antioxidant particle that is associated with the HDL particle, and it able to hydrolyze oxidized or altered lipid. It protect HDL from lipid peroxidation, and decreased PON1 activity has been proposed because dysfunctional HDL, it is premature atherosclerosis, and production of advanced glycation in product is also in hyperglycemic individuals as seen in type 2 diabetic patients. Whereas scavenger receptor beta 1, it is important enzymes reverse for cholesterol transport, and it is mediated for cholesterol facilitated bidirectional cellular cholesterol efflux, and hepatic overproduction of SR beta 1 reduces HDL level and lowers chance of atherosclerosis. These are the research tools whether we could do the PON1 activity. We would simply in the serum we could analyze the PON1 by ELISA method, that is that test kit is available, and we do by our experience on testing on PON1 and SR beta 1 in coronary artery disease patients. This is just a pilot study, and the aim of the study was to determine the serum level of two novel HDL-associated markers like PON1 and SRB1 in coronary artery disease patient and in control healthy individuals. And the study design was case control. It is of 1 year, sample size 92 subjects, suspected of CAD, 69 were angiographically proven CAD, and 23 were age-sex match control, healthy control. Serum PON1 and SR beta 1 along with other biochemical marker were done. And patients were further subdivided into 3 categories, like category 1 means have single vessel blockade, category 2 with double vessel blockade. Yes, sir, I have to conclude. Yeah. And 3 multiple vessel blockade were there. Like this, the study was planned, and we find here that the age, sex was significantly different, and we could see here that BMI and all these things were not very much significant. And here we could see that the PON1 and SR beta 1 was significantly difference was observed, whereas we could see here that there is significant difference was found in HDL level, but there is no significant differences was noted in control in comparison to cases for LDL as well as for VLDL and triacylglycerol. There is no significant differences, means lipid profile were still okay. And when we compared with the category wise with the control, we could find that the control with category 1, category 2 and category 3, there is significant differences was noted. There is no much significant difference with the habit and like alcohol use, family history, obesity, hypertension, etc. There was no much significant difference was found. And this is the sensitivity and specificity, how the case versus control we could find here that the cutoff value for PON1 and SR beta 1, and it is found significant specific, 100% specific and 75 sensitive as a biomarker. This is the relationship, dot plot relationship with the control PON1 and category PON1, category PON2 and category 3. This is the ROC curve. And conclusion that serum level of HDL, PON1 and SR beta 1 are significantly lower in CAD patient. It was inversely related to increasing severity of vessel blockade. Serum PON1 SR beta 1 could be used non-invasive tool for identification of vessel blockade and risk assessment of CAD. And further assessment of these markers could correct the functionality of HDL aspect. Limitation of the study, smaller sample size, single center study, and recommendation larger sample size to be taken for further validation, angiographically proven cases in control that will increase the sensitivity and authenticity of the study. Summary of the test ordered till date, like lipid test routinely ordered 90% HDL, LDL, TG, half of the respondent only LPA, ApoB and HSCRP. LPA, ApoB were found to be more common in more lipid-centric physician. Lipid parameter most predictive that non-HDL ApoB believed to be same. However, ApoB is ordered less often. Take home message for this pilot study was lipoprotein particle. Small dense is more prone to increase atherogenic genesis. Small dense LDL is common in CAD patient even with low or normal LDL. Oxidized LDL is more susceptible for plaque rupture and native LDL. Thus, for those subjects who are at increased risk, must evaluate for LPA, ApoB, ApoA1 and Ox LDL. Serum PON1 and SR beta 1 could be used as a non-invasive tools. Further assessment of these markers could tell the in-depth aspect of the functionality aspect of the HDL particle. And with this, I would thank the organizers and thank the chairperson for giving me some extra time. Thank you, sir.
Okay, thank you very much. So we will just go ahead like that. We'll not have the audience session. Okay. One or two questions we can have if anyone is
having. Very good talk on lipid profile. Mostly, I don't know how many people can follow this in future in the routine laboratories.
Yes, sir. Yes.
So this is not a question, a comment. Since time immemorial, we say good cholesterol and bad cholesterol. Is there any cholesterol like that?
Yes.
You have only cholesterol.
Yes, sir.
So the cholesterol attached to HDL we call good and the other is. So we use it. Sometimes we use cholesterol as HDL, sometimes HDL as cholesterol like that. This use is going on since a long time. It's only a comment.
Thank you, sir.
Okay.
Thank you. Actually, most of the things that we see here in the day-to-day life, our report goes to the clinician. Clinician asks, your lipid profile is normal, but the patient at the age of 20, 25, 30 with the recent MI. What is the scene behind that? Scene behind that, the thing is theories has been changing. No history of tobacco, no history of smoking, nothing, and all of a sudden there is MI. It means that there is some genetic factor that is responsible, and our study population should go for screening for further high-risk individuals for these. If these biomarkers is available, we could do, and who could afford, most of the important thing is that who could afford, they could evaluate for this novel marker that is upcoming.
Okay, thank you. As you said, there is no good cholesterol, no bad cholesterol. Cholesterol is
Cholesterol.
And moreover, that's what I teach my students also.
Yes, sir.
Don't say good or bad.
Yes.
It has got a very different connotation for saying a good cholesterol, bad cholesterol. And moreover, as we said, it is already time since more than half a century we are going on with the lipid profile. It is high time that we should move ahead with newer parameters and markers. Thank you, sir.
Thank you.
Any question?
Yeah, my question is, we are getting a couple of prescriptions for testing small dense LDL.
Yes.
So what's the method for testing the SEM and who is doing it?
There is a dual precipitation method. First time it was given by Hirano et al. In 2004. It was a Japanese scientist. It was a manual method for dual precipitation by sodium heparin citrate method. Nowadays it has been developed by Randox, and they are making the kit for the small dense LDL as well as PON1 and SR beta 1. So, and they are on fully automated biochemistry analyzer, they are compatible. And the cost per test, I think more over 500 to 600 rupees for a patient.
Thank you.
Thank you very much, Dr. Wahid Ali. May I request Dr. Mohanty to hand over the certificate to Dr. Mohanty? One more question? So may I request Dr. Mohanty to hand over the certificate to Dr. Wahid Ali? पूछना है तो पूछ लीजिए।